I'll just introduce you and then
Oh,
I think
fine.
we can start.
Right, sir.
Okay.
Right.
Good evening, doctors. I am Dr. Rajesh Kesavan. I am the Secretary of Diabetic Food Society of India, and I'm from Chennai. I'm very happy to introduce Dr. Prem Narayanan, who is going to take his session on glycemic control in DFU management during the pandemic. In this webinar series, this is the IJCP Reheja DFSI webinar series. So I think all of you will be aware of Dr. Prem Narayanan. He is presently the consultant and HOD of endocrinology and diabetes at Ahalya Diabetes Hospital at Palakkad. He was formerly a senior consultant endocrinologist and diabetologist at Amrita Institute of Medical Sciences at Kochi. Now he is at Ahalya, and over to you, Dr. Prem.
Thank you, sir, for the kind words of introduction. And good evening, all doctors, and welcome to this session. And also at the outset, I thank DFSI, IJCP, and the Rahej Hospital, and also especially our Dr. Arunbal sir for giving me this opportunity to interact with all of you. And so it's the topic is, as you all know, it's the glycemic control in DFU patients during this pandemic period. So it's a very important topic because we all know that diabetic foot and the glycemic control is very, very important. And so the agenda for the day will be briefly about diabetes and the diabetic foot, and effect of uncontrolled glycemia on the diabetic foot outcomes. Just to kickstart with a case, then the hypoglycemia and its effect on diabetic foot outcome, then the in-hospital hyperglycemic targets from various societies, then what are the insulin types that are available, glucose management in critically ill, glucose management in non-critical setting, perioperative care, and the concluding remarks. So this will be the agenda for the day. So diabetes, as you all know, is ever increasing in numbers, especially type 2 diabetes. And right now, even after the pandemic, even the type 1 diabetes also is on the rise. So if you give it an inch, then definitely it will take your foot. So that much important is the management of diabetes and keeping it under the control, or treating it to target, because many of the patients will be on some sort of treatments, but that does not suffice. Treating the diabetes to the targets, that is the evidence-based medicine. So keeping it to the targets is very, very important. So some of the rules, and you can see here on the foot ulcers in diabetes, the rule of 15. What is it? Around 15% of diabetic patients develop a foot ulcer in their lifetime. So you can see the number 15%, and the 15% of foot ulcer will develop osteomyelitis, and 15% of foot ulcer will end up with a amputation. And according to the IDF, for the International Diabetes Federation data, every 30 seconds, one diabetic patient is losing either his toe or his foot due to the diabetes per se itself. So that great the situation is. Then amputations in diabetes, that is a tragic rule of 50. 50% of amputations usually occur there. You can see here it's a disabling level, above knee or below knee level. So it's definitely a disabling for the patient. Then 50% of patients that end up with a second amputation in less than 5 years of the previous amputation, with the toe or with in the midfoot. If the patient has undergone one amputation, then he's definitely going to end up with another one in less than the next 5 years. And 50% of patients die in less than 5 years from usually the coronary artery disease or the cerebrovascular disease. So you can see how the macrovascular disease can affect the patient. Diabetic foot, when you come to, isn't it? You can see here There are a lot of things when a diabetic foot is landing in your clinic or in the emergency setting. The patient will be having an foot ulcer, along with that, an infected wound, or he might be in sepsis. Yes. Then other major organs may be affected, like the kidneys. Yes, he might be having a CKD or even an acute or a chronic kidney disease. He might be even already on hemodialysis. Then liver, another major organ hit by the diabetes. Yes, the NASH or the non-alcoholic steatohepatitis, cirrhosis liver, and so ending up with the liver complications, portal hypertension, and all. Cardiac, yes, coronary artery disease and heart failure. Very, very important two constituents that can complicate the diabetic foot. Then, apart from that, peripheral arterial disease, always an underestimated entity. It's very, very important. And along with that, there might be history of other macrovascular disease like the cerebrovascular disease. Then the other microvascular like the retinopathy, and also definitely when the patient is having diabetic foot, also another neuropathy might also be definitely will be there. And then the stress is very, very important because there can be emotional stress, financial stress. So all this adds to the burden of the diabetic foot, the diabetic foot attack, or even the diabetic foot syndrome. Just I will start with a case. Here, what I have put up is like one of the patient, 52-year-old male, diabetic for more than 15 years, has come with pain, redness, edema, and fever of the right foot dorsum and shin, and features suggestive of early necrotizing fasciitis. And he already has a chronic liver disease, ethanol related, and it is in child C liver disease. His A1C you can see is 10.7%, creatinine is 2.1, the altered LFT with hypoalbuminemia, yes, because of the CLD, and also the infection also adds on to the hypoalbuminemia. INR is 2.3, and echo showing ejection fraction of 60%. So these are some of the situations that we encounter in our day-to-day practice. So you can see from this graph, hyperglycemia in a diabetic foot setting. What are the mechanisms you can see here? Yes, definitely during an infection or the diabetic foot, insulin resistance increases. So you can see here adipose tissue level and the insulin resistance increases, lipolysis occurs. Free fatty acids and glycerols will be pumped to the liver, so that can increase the glucose output, and also the liver per se, the glycogenolysis also increases. Then apart from that, yes, whenever you have a foot syndrome, it is a catabolic state. So the muscle proteins also will break down. You can see here releasing amino acids and even lactate. So that also reaches the liver and increases the glycogenolysis and the glucose output, or the hepatic glucose output further increases. Then peripheral glucose utilization is reduced. Apart from that, because of the infectious status, many times the patient will be on fluids, IV fluids, glucocorticoid stress, yes. Then catecholamine release, inflammatory cytokines. The patient might be on parenteral nutrition, or sometimes they might be on enteral nutrition. That also adds to the hyperglycemia. Then the circulatory electrolytes, the disturbances like the volume depletion, hypoperfusion, acid-base balance disturbances. Tissue level, yes, reduced nitric oxide, superoxide generation, endothelial dysfunction, immune dysregulation, mitochondrial injury. So you can see multiple things are happening, leading on the patient to sepsis, multi-organ failure, and resulting in the increased mortality. So this is one of the clinical profile data from Amrita, done by one of our diabetes educator student, along with Dr. Arun Bal and myself as a co-guide. And nearly we looked into data of 413 patients, and the mean duration of diabetes of all these foot patients was around 15.5 years. The mean age you can see 62 plus or minus 11. So usually 50 to 75 is a major chunk of diabetic foot patients that reach your clinics or into the wards. So that is a major age group affected. You can see the mean A1C is 9.5 nearly, plus or minus 5%. So you can see how the glycemic control of the diabetic foot patients are there. Then another study again from the South India, Chennai, Dr. Vijay Vishwanathan and also Dr. A.R. Ramachandran and the others. Clinical profile was looked into. It was a retrospective study of 374 patients. Again, the A1C was 10.2 plus or minus 1.6%. Then again, another study from the South itself, clinical microbiological profile, again showing the high A1C of 10.3% in the diabetic foot patient. So the glycemic status. So that's what I wanted to stress from these studies, the uncontrolled glycemic status and how it can affect the wound healing. Yes, at ages or the advanced glycation end products induce a pro-inflammatory cytokines like the TNF, IL-1 beta, etc. Increased reactive oxygen species, vascular and immune dysfunction. It also affects the collagen synthesis, major protein in the healing of the wounds. So all will be affected. There will be changes in the cellular morphology, decreased proliferation of the tissues, and abnormal differentiation of the keratinocytes, all leading to delayed wound healing in the diabetics. And another, you can see here study from 2004, a paper which showed that the insulin degrading enzyme IDE in wound fluid and healing. So increased activity of insulin degrading enzyme in the wound fluid was shown, and this IDE activity in the wound was found to be positively correlated with the A1C level. So that is very, very important. You can see here, so as the A1C increases in the wound fluid, the insulin degrading enzyme activities also increases. And also you can see here, the wound healing also will be affected, resulting in increased risk of amputations. So it's very prudent to shift the patient from OADs to insulin during the time of wound or wound healing phases. So that always helps in wound healing also. The relationship between A1C values and healing time for lower extremity ulcers in individuals with diabetes. So you can see here, the red one is the A1C between 4 to 7. The violet one is A1C of 7 to 10. And yellow one is A1C more than 10. So the A1C is in the range of less than 7 or around 7. So the healing time is lesser compared to, you can see here, the violet one and also the yellow one. You can see here as the A1C level increases, you can see the healing time is also prolonged. So that's a definite correlation between the bad glycemic control and the wound healing. And this is another meta-analysis which has looked into the A1C level and the lower extremity amputation risk. And this has shown that high level of A1C is an important risk factor for lower extremity amputation in patients with diabetes. And again, another article from the South Korea. So risk factors for major amputation in the hospitalized diabetic foot patients. So what are the risk factors for major amputation? Bone invasion or the osteomyelitis. Then dialysis, other gastrointestinal disorders like even the chronic liver disease. Hind foot ulcers, yes, definitely. We all know that is a very tough phase to get the hind foot ulcers to get healed. And low hemoglobin, anemia, yes, definitely you'll have to address the anemia and bad glycemic control. The fasting plasma glucose was the one that was looked into in this study, but we have shown that various studies that the A1C level per se can also worsen the wound healing. And another paper from JCM in November 2019, association of inpatient glucose measurement with amputation in patients hospitalized with acute diabetic foot. So they have evaluated the relationship of hyperglycemia, and glucose variability during hospitalization with the amputation result in the hospitalized patients with diabetic foot. So nearly 418 patients and nearly 46,000 or 45,500 glucose measurements was analyzed into. And here you can see hypoglycemia and severe hypoglycemia was higher. You can see 65% versus 42% in those who underwent major amputation compared to no major amputation. Even severe hypoglycemia was higher with those who underwent major amputation compared to no major amputation. Also, hyperglycemia, you can see here, 80% versus 70% was more, or the hyperglycemia was also higher in patients who underwent major amputation compared to no major amputation. And even severe hyperglycemia was also higher when it was not statistically significant. And the length of hospitalization also was dependent on the hyperglycemia. When the hyperglycemia was prolonged, or it was on the higher side, the length of hospitalization was also more. And hypoglycemia also, when there was hypo or no hypo compared to, and even you can see here severe hypoglycemia, there was prolonged hospital stay. So that shows the balance that is required, be it a hyperglycemia or hypoglycemia. Balance will be the key in the diabetic food management. Next, definition of hyperglycemia. So what is this hyperglycemia? In hospital patients, hyperglycemia is defined as blood glucose more than 140 milligram per deciliter, or an A1C more than more than or equal to 6.5 percentage preceding the hospitalization. Hypoglycemia can be divided into three categories. Level 1, when the glucose is between 54 to 70. Level 2, blood glucose less than 54, typically the threshold for neuroglycopenic symptoms. And level 3, hypoglycemia is a clinical event characterized by altered mental status and physical functioning that requires assistance from another person for recovery. So these are the three levels of hypoglycemia that you will have to know. Then ADA has recommended that when caring for hospitalized patients with diabetes, consult with a specialized diabetes or glucose management team whenever possible. And in a cross-section comparison, rate of both hyper and hypo were reduced by 30 to 40% when the team was managing the glycemic control. Next, we move on to the glycemic targets, which are recommended from the various esteemed societies, the guidelines. AD and ACE, you can see here, in ICU setting, initiate insulin therapy for persistent hyperglycemia with glucose more than 180 milligram per deciliter. And the treatment goal will be to target a glucose between 140 to 180. So this is in the ICU setting. Non-ICU setting, no specific guidelines are on that, but if already treated with insulin, the pre-meal glucose target should be less than 140 and the random glucose levels less than 180. And more stringent targets would be required. Previously, the patient was tightly controlled diabetes, and the patient is having severe comorbid illnesses, then lesser stringent targets can be advised. So that will be based on the patient parameters. Then the Endocrine Society guidelines on the non-ICU setting, published in 2012, pre-meal glucose target less than 140 and random blood glucose less than 180, almost similar to the previous. And glucose less than 180 to 200 is appropriate in patients with terminal illness, limited life expectancy, and also those at higher risk for hypoglycemia. In this category, we are giving a little bit relaxed glycemic control. Up to 200 or around will be fine. Then the American College of Physicians, the ICU setting, they recommend against intensive insulin therapy in patients with or without diabetes in surgical or medical ICU. And they're given the target glucose between a white, you can see 140 to 200 is fine, from the ECP. Then from the Critical Care Society guidelines, blood glucose more than 150, they have mentioned that should trigger the insulin therapy. and the goal should be to maintain it less than 150. And in those, like the where hypoglycemia need to avoid, like the having terminal illness and all, they relaxed it up to less than 180. So there's also always a controversy between the whether the intensive versus the conventional glycemic control. So this from the NICE sugar recommendation, this was a multi-center parallel group RCT randomized trial with intensive group of 80 to 81 to 108, conventional group target of 140 to 180. No significant benefit with intensive glycemic control was shown in the study. 90-day mortality was higher with intensive group, and the frequency of hypoglycemia in the intensive arm was 6.8% versus 0.5% in the lesser intensive group. So that hypo was more in the intensive group. Those with hypoglycemia had two-fold increase in the mortality compared to patients without hypoglycemia. Next, we move on to glucose lowering strategies in the hospitalized patients. So first, critically ill setting. In any critically ill setting, definitely insulin should be the drug of choice for managing the hyperglycemia. And if required, then in critically ill setting, yes, definitely continuous intravenous insulin infusion with the pump should be the modality of treatment. And the glycemia can be titrated according to the glycemic fluctuations, and the insulin dose can be adjusted according to the changes in the glycemic levels. Non-critical care setting. That means the patient is admitted with a foot ulcer, but he is not in an ICU setting. So here you can consider if the patient is having poor oral intake or the patient has been put NPO, then a basal insulin with intermittent monitoring of the blood glucose and giving the correction bolus doses can be done. But if the patient is okay, he's having a good nutrition intake is good, then you can go for the usual basal bolus regimen, that is a basal plus prandial plus correction doses as a depending on the glycemic status. So what is this correction dose and all, I will be coming up in the further upcoming slides. And another important thing is that the sliding scale use alone is strongly discouraged. Strongly discouraged, because previously we used to have the sliding scale, like if it was 180 to 220, give 6 units. If it was 140 to 180, give 4 units. So like that, the sliding scale was regimen. Sliding scale is strongly discouraged these days, and we do not use it these days. Now, little bit about the different types of insulins that are available in our setting, and so there is bolus insulin, there is basal insulin, there is premixed insulin. Bolus can be divided into human recombinant insulin and insulin analogues. And the basal insulin can be the first generation, and right now, even now, we have the second generation basal insulins also. And also you can put it like there is the intermediate insulin. Intermediate acting will be the NPH, and the premix, as you all know, is a premixed one, like the 3070 or the 5050, etc. And as you all know, like it's now nearly the 2021 is nearing, so it's the 100 years of insulin is now coming up, and still, so it's one of the major modality in the treatment of the diabetes, and a great breakthrough from the pandemic method and pest. And bolus insulin, as you have put up, is the human insulin or the short acting or the regular insulin, known by several names. Onset of action 30 to 45 minutes with a peak duration at 2 to 4 hours will be the peak duration. Total duration of action of that human insulin will be 4 to 8 hours. Then you have the insulin analogues. The advantage is that they have the faster onset of action of around 10 to 20 minutes. So you do not have to wait for half an hour like the human category of insulin. So you can administer 10 to 15 minutes before the meal, and then the meal can be taken. And apart from that, the peak action occurs at 30 to 90 minutes. So it will be able to cut off the 1 to 1.5 hour post-meal peaks that happen, especially in the Indian setting. We are loaded with all carb in our diet, so the early rise in the postprandial levels can be cut off with the faster acting analogs like the aspart, lispro, and also glulysin. And the total duration of action of the rapid acting analogs will be a little bit shorter compared to the regular insulin. So it is only around 3 to 5 hours. Then the another bolus category of insulin is the ultra fast acting. The available one is a faster acting aspart by the name of Fias, and even the lispro faster acting or the lispro ultra fast acting lispro is also in the chain to get released. FDA is approved, and the onset of action is less than 5 minutes. So it is a faster onset of action. So it is almost going to mimic the natural release of insulin that occurs in a normal human being when you're taking a diet. And the peak action is 30 to 90 and total duration 3 to 5 hours. Intermediate acting basal insulin, that is a neutral protamine hystrone. So neutral means that shows the pH is neutral, and protamine is the one, or the protamine zinc is the one that is added to the human regular insulin. Hystrone is named after the scientist who discovered this. That's why the NPH insulin or the crystal insulin. And the onset of action at 1 to 2 hours, and there is a peak definitely at 4 to 8 hours. It is the peak that happens at 4 to 8 hours, and total duration is 12 to 24 hours and can be administered once or twice daily. So it is a regular human insulin added with these components that has made it to prolong the action, and hence it became the intermediate acting basal insulin. Then the long acting basal insulin started with the Jetimer, the older generation. Onset at 1 to 2 hours, peak at 6 to 10 hours. Yes, it also has a peak. Total duration is 16 to 24. Still, it is not covering up the 24 hours time. Then we have the glargine, onset at 60 to 120 minutes. No pronounced peak, but usually, but a small peak can happen at around 4 to 6 hours. Compared to NPH, it is very, very less. And the duration of action is approximately 24 hours. It's not entire 24, but approximately it reaches 24 hours of action. And now we have the ultra long acting basal insulins available in the setting, and Degludec and Glargine U300, onset at 1 to 2 hours, no pronounced peak. So you can put it like it's almost like the peakless insulin categories, and the duration of action up to 72 hours. Next, we come back again to the critically ill patients. As I have already said, critically ill patient, IV insulin infusion. Multiple protocols are available, but usually what we follow is a Yale protocol is the one commonly that is being followed in most of the ICU setting. So for any ideal infusion protocol, it should be easily orderable and implementable. Then it should be effective. It should be able to maintain the target glycemic levels. It should be safe, with minimal risk of hypoglycemia. And it should also be able to be executed by the nursing staff in a relatively simpler way in response to a physician order. The Yale protocol: start intensive IV insulin therapy in critically ill patients when blood glucose is more than 180 milligram per deciliter. IV insulin therapy should be given with a short-acting regular human insulin, preferably using an infusion pump. And 1 unit, you can see how you can take the or the dilution of the insulin. It should be like 1 unit recombinant human insulin in 1 cc of 0.9% saline. So, for example, if you're taking the 40 IU vial, 40 IU vial contains 1 ml will contain 40 units. So, if you're taking 1 ml of the 40 units, you can dilute it with into the 39 ml saline. So, 39 ml of saline with 1 ml of insulin. So that will make total of 40 ml with the 40 units insulin. So that will make to 1 unit in 1 ml of the saline. And how to start, what dose to start with? Usually what we say or what we do is that the patient is having hyperglycemia, first hydrate the patient. So hydration itself will bring down some of the hyperglycemia values, because patient already will be in a volume depleted state in those hyperglycemic patients. So if the patient is having a 500 or a 450 and all, if possible, no other contraindication for hydration, hydrate the patient, and then again recheck the blood glucose level after 15 minutes, and definitely some reduction will be there. And based on that, you can start by dividing the blood glucose values by the 100, and then rounding it off to the nearest decimal, and that should be the starting dose. I'll be coming up with an example so that it will be more clear for you. Another important thing is that the bolus dose is not recommended these days, and it has been taken off. That is one of the recent change in concept, because previously what we used to do is, like when you see a blood glucose level of 400 in an emergency setting, we used to give a blanket 10 unit SFQ and a blanket 10 unit IV, isn't it? So that bolus doses are not recommended these days. That is out. Initiating dose calculation. So as I have already put up, so if the patient is having a glucose level of 400, you can divide it by 400 by 100, divided by 100. So 400 by 100 will be 4. So the starting dose will be 4 units per hour. So how to monitor a patient on insulin infusion? Check the blood glucose hourly until the values are stable. Stable means the 3 consecutive values should be within the range of 140 to 180. So once you have reached that level, you can reduce the monitoring rate to 2 hourly. And again, if there is no change in the clinical condition, no change in the nutrition of the patient, and the glycemic status is also stable within the range of, you can again come down with the monitoring from 2 hourly to 4 hourly. So that means the relaxation in the monitoring frequency. Then again, you can see here change in the infusion rate. So you have started the patient on insulin infusion. It's okay. So, and once if you see the blood glucose is after you have started, and the blood glucose is less than 50, you will have to discontinue the infusion for the time being, because the patient has gone to hypoglycemia, and so you have to correct the hypoglycemia with the dextrose of 25 grams intravenously. Recheck after 15 minutes. When the blood glucose is more than 100 milligram per deciliter, when it has reached that level, wait for 1 hour and restart at 50% of the original rate. So at the time of stopping, if the rate of infusion was 2 units or 2 ml per hour, when you are restarting after the correction of hypoglycemia, it should be 1 unit per hour only. So that is an important change in infusion rate. And when you are following with the blood glucose monitoring on infusion, and the blood glucose has come to between 50 to 74 milligram per deciliter, the patient is symptomatic, or if the patient is already on ventilator setting and all, and you are not able to assess hypoglycemia, definitely discontinue the infusion, correct the hypoglycemia if necessary by giving 25 gram dextrose, recheck after 15 minutes, and again when the blood glucose level is more than 100, wait for 1 hour and then restart at 50% of the original rate. So these are the two things: when the blood glucose level is less than 50 and the blood glucose level is between 50 to 74. And you have started the infusion and the blood glucose is more than 75, just closely look at the chart. There are 4 important columns, and fifth one is the instruction. So you are checking the patient, and the glucose monitoring is done hourly, and it falls to one of the ranges. Say like if it is 100, or if it is 150, or is it again above 200. One of the columns should be chosen, and then you have see, you can see here various rows are also there. So based on that, you will have to look into the which row. Row is based on the per hour decrease in the glucose that has happened in the patient. Say for example, the patient's blood glucose, the falling rate, previously it was 100 and now it is 75. So the falling rate is 25 milligram per deciliter per hour. So you'll have to choose one of the row, and again you'll have to come to the right end column of instruction and see what is the instruction that is given. Sometimes it will be no infusion. Sometimes it will be to increase the infusion by delta. Sometimes it will be increase the infusion by 2 delta, depending on which is the row and column that is coming to our patient. So that I will make it clear with an example. And how to change the infusion rate after calculating the delta or the 2 delta. Accordingly, based on the current rate, we'll have to calculate the delta or the 2 delta, and accordingly you'll have to increase or you will have to decrease the rate. So again, I shall make it clearer with an example. So taking a 54-year-old male, type 2 diabetic with sepsis, the RBS of the patient is 485. He has come to the emergency room. So that is after the hydrating the patient, the RBS is 485. So what dose you should start with? Divide the 485 by 100. So 485 by 100 will be 4.85. So round it off to the nearest whole number. 4.85 can be rounded to 5. So we will start this patient with a 5 units per hour as a starting rate. 1 hour later, usually what I told you, 1 hour later, every 1 hour you will have to check the RBS or if the patient is on insulin infusion. And so 1 hour later, you can see here the RBS was 390. So before the infusion, it was 485 and now it is 390. So the difference or the falling rate was 485 minus 390. So it is 95 milligram per deciliter per hour. So that is the falling rate. So how will you choose it? So on the right hand top, you can see. So the present blood glucose is 390. So which will be the column? It will be the fourth column, that is blood glucose more than 200. So it is still above 200. And what is the falling rate? It is 95 milligram per deciliter hour. So it will come down, come down, come down, and you'll be choosing this row. You can see here, blood glucose fall of 70 to 6 to 100 milligram per deciliter per hour. So ours is 95, so we will be choosing this row. And again, we look into the instruction column. So what is instruction column telling? Decrease the infusion by delta. So we'll have to decrease the infusion by delta. So how do you calculate the delta? So here you can see our current rate was 5 unit per hour. 5 unit per hour means you can see it is coming between 3 to 6, isn't it? So what is the delta here? It is, you can see 1. Delta is the rate of change is 1. So you have to decrease the infusion by delta. That means you have to reduce the rate by 1 unit per hour. So from 5 unit per hour, the new rate of infusion will be 4 units per hour. So it is as simple as that. And another important point that I forgot to mention is that before starting insulin infusion, always make sure that the potassium of the patient is in the normal state. The potassium is less than 3.5. Correct the potassium for the hypokalemia and then only start the infusion, because insulin will drive the glucose, and along with that, potassium will also be driven into the cell, and it can worsen the hypokalemia. And as you know, hypokalemia can worsen the cardiac status and also resulting in the increased risk of arrhythmia. So that is one important point that you should keep in mind. Then after the critical state is over, infusion, you are going to stop the infusion. A dose of subcutaneous basal insulin should be given 2 to 4 hours before the intravenous infusion is discontinued. So if you want to stop the IV infusion and change the patient to subcutaneous insulin, always calculate the total dosage requirement. And then from that, the basal dose requirement. And the basal dose should be given at least 2 to 4 4 hours before the IV infusion is discontinued. Definitely, this is very important point that you should keep in mind. People make mistake on that, and that results again in the havoc rise in the glycemic status at glycemic levels after transitioning to subcutaneous infusion insulin. Then transitioning the IV to subcutaneous insulin. For inpatients with hyperglycemia, transitioning from IV to subcu and taking oral diet. So you are stopping the insulin infusion and changing to subcu and oral diet. The patient will be taking the diet. Then you can calculate the total dosage requirement. 50% can be given as the basal. Basal insulin can be either the first generations like the glargine. Determined we do not often use it these days, and or if you are giving the second generation based insulin, the glucoglazine U300 that also can be given. With the 50% of the total dose will be the basal insulin, and the rest will be the prandial dose, and along with it the supplemental correction dose as and when required. I will be coming up to the correction dose again in the subsequent slides. And if you are transitioning the patient from IV infusion to subcutaneous, but is not good on the oral diet, is on, like say for example, is on the IV, is on rice tube feeding, in that sort of patients, or is having vomiting, so or something like that, and is not going to tolerate oral feeds. So in that sort of patient, if you want to change from IV to subcu, you can make it the like 80% of the calculated dose you give it as basal insulin, and the rest you can check the blood glucose, or the 20% you can keep it as prandial divided into 3 times, and along with that supplemental correction doses as and when required. Next, we move on to glucose management in the non-critically ill. So right now, till now we were seeing critically ill patients. Now the patient is non-critically ill. Medical nutrition therapy, very important, because it should be included as component of the glycemic management for all hospitalized patients with diabetes and hyperglycemia. Very, very important, because that makes a big change in the glycemic control and attaining an earlier glycemic control status. Meals with a consistent amount of carbohydrate be provided at each meal time. So that should be helped out by the nutritionist in your team. So there comes the importance of the team. And the doses can be set according to the carbohydrate given in each meal. Then transition from home to hospital. The patient is non-critically ill and is being admitted for the foot ulcer, which is not critically ill. Insulin therapy is always a preferred, as I have already put up. Discontinue the OAD in any acute illness. Yes, especially I've seen recently the SGLT2 inhibitors being rampantly used. Be careful, because it causes volume depletion and euglycemic decay also. It's also happening. So acute illness, stop all these OADs, give the insulin. And those who are already on insulin, definitely the intensification of dose or dose modification will be required. Then the basal bolus regimen initiation. Many people will have some sort of query or doubt or how to start a basal bolus regimen in a patient. It all happens with the total daily dosage. So how to set the total daily dosage? So these are all based on the definitely the clinical experience of the physician also adds to it, and patient clinical parameters also should be considered. In those who are aged above 70 years and EGFR is less than 60, so you can guardedly start with a lower dosage of 0.2 to 0.3 unit per kilogram of body weight of total dosage, which can be split into 40 to 50% as basal and the rest as a prandial with correction doses as and when required. If the patient is not less than 70 years and the EGFR is above 60, you can make it in a higher dosage of starting, like 4.4 unit per kilogram of body weight. And if the patient is having very high glycemic levels, very high A1Cs, to start with, even you can start with half the body weight, like 0.5 unit per kilogram of body weight total dosage can be initiated with. Distribute as put up, like 50 to 40 to 50% as basal and the rest as a bolus with the correction doses as required. Basal, you can choose, yes, definitely. And if you're giving the basal insulin like glargine, the thing is that you should maintain to give it at the same time of the day because there's roughly 24 hours of action. Prandial insulin is usually given in 3 equally divided doses before each meal. And again, the recombinant insulins, human recombinant insulins or the regular insulins, half an hour should be given, because that is also one mistake that is commonly happening. All the all the IP settings, staff nurses will give it and go, and even sometimes after the meal, many of them tell them to a patient to take the meal and then give the insulin, so that is not going to surface, so that will increase the risk of the hyper the glycemic fluctuations. Then the adjustments of the total daily dosage re-evaluate based on the previous 24-hour glycemia. You can give a 24 to 48 hours time before changing the dosage. And after 48 hours, the glucose values are more than 180 and the no risk of hypo, can increase the dose, total dose by 10 to 20% with the divisions as already I have previously mentioned. And if the glucose levels consistently above 200, again increase the dosage by 30% of total dose. Previously, say for example, the 50 units was the total daily dosage previously. 30% of it can be increased after the 48 hours, nearly 24 to 48 hours of monitoring. Any hypoglycemia is happening, come down with the dosage with a 20% reduction in the total daily dosage. 10 to 20% you can put it based on the severity of the hypoglycemia. Then sliding scale versus the supplemental or the correction scale. Very important, please note it out. Sliding scale, a set amount of insulin is administered for hyperglycemia without regard to the timing of the food. Presence or absence of pre-existing insulin administration is not considered. Patient's insulin sensitivity is not taken into the account, and it treats the hyperglycemia that has already occurred. You're just giving, checking 6-hourly blood glucose level, and you're treating that. So these are the problems in that sort of situation with the sliding scale. You're treating a hyperglycemia which has already occurred. No, what we want to treat the hyperglycemia. We want to prevent the rise in blood glucose or levels that can happen. So sliding scale is not recommended. Please note this one. So next is correction scale. So what is this correction? It is a dose which is given together with the usual bolus dose of insulin. Say the prandial dose was 5 units, but for example, if the blood glucose pre-meal was 200, so we want to keep it less than 140, but it is 200, so it is 660 above the target. So we'll have to consider insulin to correct that 60 milligram per deciliter. So hence it is called a correction insulin dose. It considers insulin sensitivity, it takes into account the patient comorbidities, and it also takes into the patient's nutrition status. So the correction scale is the, I will be putting it up. Yeah. So here is the correction scale. It is divided into 3 columns. You can see 4 columns. On the left hand column will be the blood glucose based on the blood glucose levels. 3 columns are the insulin sensitive column, usual column, and insulin resistant column. So as you can see here, the blood glucose is more than 140 to 180. If it is the patient falls into the insulin sensitive column, correction dose is 2 units to correct the blood glucose level. If he falls in the usual column, 4 units will be required to correct the off-target blood glucose level. If it's insulin resistant column, it will be 6 units. Like that, based on the blood glucose levels and insulin sensitivity, there are supplemental insulin scale doses. So who falls into this, all these each column? You can see those patients who are taking all the meals, not critically ill, they fall into the usual column. So that will be the, sorry, this is a usual column. So you'll have to add up the correction dose to the prandial dose based on this column. Then if the patient is elderly, having multiple organ dysfunction or the major organ dysfunction, renal, liver, heart, or he's not taking meals properly, then you can follow the sensitive column. You can see here, this will be the sensitive column. and the patient is on steroids or already the pre-admission total daily dose, he was taking more than 80 units, take or put him into the insulin resistant column. So that will be this insulin resistant column correction you'll have to choose. So likewise, and so the how to adjust the columns. Sometimes you will like to come down to the columns also. The patient's fasting and pre-meal glucose are more than 140 off target. It's more than 140 and no hypoglycemia happening. So after monitoring for a you can see here a period of 3 to 5 days, still not happening. Yes, you can change the column of correction from sensitive to usual. The patient was already in usual column, change it from usual to the resistant column. So likewise, you are stepwisely, gradedly increasing the insulin correction doses also based on the clinical status of the patient. The patient develops of hypoglycemia less than 70. You can come down with the column also. You can see here resistant to usual, usual to sensitive. And whether the regular or the bolus insulin type of insulin matters, yes, there are studies which have shown that the analog is better than the regular human insulin because analogs can reduce the mortality, shorter length of hospital stay, and modestly better glycemic control. So, if possible, you can go in for analog insulins. The patient is affordable. So the one of the patient which I had shown to start with was started with regular plus NPH. Initially, we can see here glycemic fluctuations were there, and we had corrected with the supplemental correction doses were also given. And follow up, you can see here how beautifully it has come down to the target of less than 180s. And at discharge, he was discharged. You can see here he was having CLD, hence very high doses was required for the actrapid and also the NPH. So intensive versus conventional glycemic control for treating diabetic foot ulcer. This is a Cochrane review which has showed that the current review failed to find any completed randomized clinical trial on this topic. Whether the intensive versus control will how it turns out into the effect on the foot ulcer per se. Perioperative consideration, the final part. Yes, there currently exists no evidence-based guideline dictating when to cancel surgery due to hyperglycemia. But elective surgery should not be done in patients on decay and HHS, that's hyperosmolar coma. Yale Hospital recommends cancellation when the blood glucose is more than 400. So that was a hospital recommendation, and even the Boston Medical Center recommends cancelling the surgery when blood glucose more than 500. But AD and all has no recommendations on that, so you can do it based on the hospital recommendations or the based on the surgeon's decision also. It's a risk benefit needs to be considered. Major surgeries, some surgeries perioperatively you'll have to manage with GI care, that is glucose insulin with potassium infusion. How is it made? 500 ml of 5% dextrose with 8 units insulin, that is 0.3 unit per gram glucose is the one. So hence it is 8 units. Short-acting insulin can be regular or the analog with 1 ampule of potassium of 7.5% kcal. And you can start the infusion at the morning time. So the patient is posted for surgery. You can start at 8 to 9 a.m. In the day of surgery. Started at the rate of 100 ml per hour. And you can see here the titration rates. You can monitor the blood glucose hourly. And you can see the infusion rate can accordingly be titrated. And perioperative care target is 140 to 180, and discontinue OAD and non-insulin injectables. That's mentioned in the GLP-1. A reduction of insulin given the evening before the surgery by 25% can be done. The patient is well controlled or tightly controlled, or a prolonged surgery for major amputation is planned. Basal can be come down by 25%. On the day of surgery, give half of the NPH dose or 60 to 80% doses of the long-acting analog, so that you can prevent the hypoglycemia during the surgeries that can happen, and monitor the blood glucose on table and all, at least if possible every 4 to 6 hourly. On table even hourly to 2 hourly can also be done. Minor surgical procedures. Type 1 diabetes, continue insulin dosing, no stoppage of insulin. Type 2 on insulin, continue the same. not on insulin, monitor the glucose 2 hourly. And OAD can be started with the first meal after the surgery. And transition from the hospital to the ambulatory setting. Yes, medical reconciliation and structured discharge should be there. It should be communicated, the dose and the timing, everything should be there. Medication must be definitely checked, and the changes must be informed, and schedule follow-up appointments. And finally, just on briefly about the home blood glucose monitoring. Patients on OADs, no specific recommendations. Type 2 diabetic and SOS monitoring can be done. OAD plus basal insulin, yes, definitely at least 0 to 3 times per day monitoring can be done. Those on basal bolus insulin, type 2 diabetes, 6 to 10 times per day monitoring may be required. And for type 1 diabetic, a little bit more frequent might also be required, like 4 to 10 times per day. And so these are some of the ways of checking. You can see here the paired checking. So here the before lunch, BL and AL is after lunch. 7 days, the before and after lunch was checked. Then the 7-point profile, isn't it? That is a 3 pre-meals with the 3 post-meal and the midnight value. Bedtime. The difference is that the Westerners, they take the dinner usually by 6 to 7. Hence the bedtime check usually at the 10 o'clock and all. But in our setting, our dinner is a little bit late, so we usually go for the 7-point checking, not at the bedtime, the 3 a.m. values that we go for. Then sometimes like the staggered profile, you can see here the breakfast one day, pre-breakfast and post-breakfast. The another day, pre-lunch, post-lunch, and another day, pre-dinner, post-dinner, and one early morning sample can also be checked. So like that, the staggered profile that can also be done. And finally, to conclude, before the right now, from the we are moving the glucose monitoring from the days of SMBG to A1C to CGMS. Yes, to available, and even Dexcom is also available, but not routinely used. Abbott Libre system is available. Libre Pro, which is a professional one where you cannot see the readings, but now right now we have the Freestyle Libre, which is available, where the real-time monitoring is available, and it does not require calibration, unlike the Medtronic system of Guardian Connect, where twice daily calibration with the glucose monitoring is required. And likewise, so the CGMS that itself is a huge topic and not going detail into it. So these are the systems that are available these days even to fine-tune the glycemic control for our patients. So this is just a graph that can be obtained from the ambulatory glucose profile, and the median line you can see here the time in range concept from the ADA. So the recommended one is that time in range to keep it 70% at least is the time. So 70% of the time in 24 hours, that is around 16 hours, 16 to 17 hours, the patient should be in the target range of 80 to 180 is the recommendation. So take home message, glycemic control in DF, that is a diabetic foot patient, important for a favorable overall outcome. Insulin holds the key in glycemic control in the in-hospital setting. Sliding scale should not be used, and also bolus doses of for hyperglycemia should not be used, and comorbidity also holds key in the glycemic management in the diabetic foot patients. Thank you all for the patient listening. Any questions, queries, or comments? I'm ready to take it.
Dr. Prem, that was a very interesting lecture. Being a surgeon, I think a lot of uh, things were very, very clear how to manage insulin. Again,
Right.
why sliding scale is not recommended, the AL
Exactly.
protocol, and how do you look at, I mean, when do you have to repeat the sugars again,
Yes.
and how do you increase the amount of insulin level in the infusion,
Exactly.
and again what is the preoperative protocol, the
Exactly.
nutrition that needs to be taken. A very, very excellent discussion that you have shared with us. Let
Yes.
me just go for the questions, sir,
Definitely.
just for a minute.
Sure, sir.
uh, I think the first question is latest new range value of HbA1c.
What is the latest?
What is the present guidelines as far as HbA1c values for diagnosis and control of diabetes?
Yes, so the diagnosis part, 6.5 percentage is still the cutoff that we take. And based on not on A1C alone for a diagnostic part, so critical care setting, as I've already put up, the persistently the values are more than 180, at least 3 or 4 values. You're seeing more than 180, definitely you should start therapy in the critical care setting. But in a non-critical care setting, already if the A1C is more than 6.5 percentage, then definitely you'll have to take it as a diabetes, and you'll have to treat the patient to the target. The target I have said, like the pre-meal target less than 140 and the RBS less than 180. So that is there's no change on that. Like the A1C diagnostic part. But if in a usual, if you're putting up, barring apart from the DFU, just in a general patient, A1C, do not go for A1C alone. Should definitely have the fasting plasma glucose, and if possible, the gold standard OGTT can also be done, and you can correlate. If the two are going in the direction of the diabetes, definitely you can label the patient as diabetic one, because many times you see a patient with HbA1c of 6.7 percentage, but the fasting is in the range of, you can say, around 112. So in that case, if you can go for an OGTT also, and if the OGTT definitely it will be crossing around 200, so two values are in favorable, definitely then you can label the patient as diabetic.
The next question is fasting sugar or PPBS, which is most important in DFU management?
So both are important. So as I already put up, fasting plasma glucose and postprandial plasma glucose, both are very, very important there. Because any, be it fasting or be it postprandial, higher glycemic levels definitely results in endothelial dysfunction and oxidative stress. So be it fasting or postprandial. So controlling both are very, very important. And the physiology is different. Fasting plasma glucose high means the patient has a good amount of liver insulin resistance, and postprandial high means there is a good amount of peripheral resistance also. So peripheral insulin resistance also. The controlling or treating to target of fasting and postprandial, both are very, very important. Be it DFU or non-DFU, both are important.
Um, has the pandemic worsened glycemic control? An interesting question.
Yes, sir. Definitely, it has. I would say that mixed bag. Some patients have become, because of the worry of getting the COVID-19 initially. What I saw during the pandemic when it was started in the May time and all, those who were on uncontrolled status, they were seemed to be in more into a controlled status. They were taking the medications regularly and all. But of later, I'm saying that that has been gone. Might be the fear has gone away with the pandemic. People are living with the COVID-19 and they are back to their square normal of uncontrolled status. So yes, it is worsening, and also new onset diabetes is on the rise, especially even type 1 diabetes also on the rise after the pandemic has started. So we all know that the proposed mechanism of the COVID-19 virus entering the beta cells and even causing the beta cell destruction and all are proposed mechanisms. So definite worsening of the glycemic status is seen these days.
A number of patients who have got diagnosed as COVID were put on steroids.
Yes, sir.
Anything on managing diabetes
Yes, so that
when
is very,
patient
very
is on
important.
steroid?
Very, very important, because after that dexamethasone study, a lot of patients have been put on unnecessarily on steroids also. So that has made a havoc in the glucose levels. And steroid-induced hyperglycemia per se, that is a very big topic to discuss. So, and that is a very important point that you have put up, that dexamethasone usage, I would suggest for your COVID patients, do it wisely and based on the recommendations on the usage of dexamethasone. Do not put it for all, because that has worsened the glycemic and other metabolic parameters to the adverse levels. So please do not use it for all. Based on the necessity, you can start. And in that sort of situations, always better to to change the patient to the insulin, so that you can control the glycemic status better with the steroids.
Uh, Another question: a
Sir.
drug of choice for a diabetic patient who has chronic renal failure.
Yeah. So I mean, in the setting of DFA, as I have already put up, I will go for an insulin, because chronic renal failure, you have put up the stage. Maybe the patient is having stage 4, stage 5 infection already. Yes, no doubt, insulin, go for it. If you're taking up a non-DFU patient, then you have all the, I mean, guidelines you have. Even DPP4s can be used with the dose modifications, and even the glipizide, glycoside with the reduced dosages. Glimepiride usually I avoid. Glibenclamide I avoid in the CKD setting. So it all depends on the stage of the kidney, because chronic renal failure itself, you can see here, there are various stages, starting from the even those with the filtration with the above 18 to 90 to the stage of ESRD. So a lot of stages. So that per se itself is a topic for another discussion. But overall, if you take it in the DFU setting, I will be going for the insulin.
Okay, again in that nutrition, this thing, no. Uh, Nowadays, I think a lot of people are asking to cut down on carbohydrates, increase the protein intake.
Yes.
What is your take on? Some even say skip carbohydrates. So, what is your take on that?
Right. So I think you are pointing at the most probably the LCHF type of diet,
Yeah.
for the reverse and reversibility of type 2 diabetes. Yes, a lot of things are now, discussions are happening on the nutrition part, on the type 2 diabetes and reversibility. But overall, as you know, for a short-term weight loss, definitely benefits are seen, but we do not have a long-term data like the hard endpoint data. We do not have on the cardiac, because we are all taking it based on the lipid levels only. That's our indirect surrogate or the biomarkers based studies are only there. You do not have hard endpoints like what happens to the number of heart attack or events. We'll have to wait for a pretty long time for, especially in those patients who are young patients you are putting in keto and you are monitoring for the hard endpoints. It is a pretty long study. So short term, yes, based on the advice from a specialist who is in managing these sort of nutrition models, definitely you can take. But long term, like beyond 3 to 6 months, we do not have data. So I won't be suggesting it to go for it beyond that. So all these models, nutrition models, they have their own fallacies, and no good model is there, because any model of nutrition, be it intermittent fasting, Mediterranean diet, or this sort of diet, or X, Y, Z, whichever be the diet, after a period of 3 to 6 months, your body is definitely going to finds an alternative path, and regain is bound to happen. It is not like you are going to do an LCHF diet and you are going to continuously your slope of weight loss is coming down up to you are going to reach a point of 0 kilogram. No, it is not, because the weight loss is going to come down, and by the time of 2 to 3 months, yes, definitely it is going to start going up. So no good model is there. Short term, yes, benefits are shown with all these fallacy diets, but I would suggest you take the advice of a specialist, and then accordingly following that will be the best way, because those who are on insulin and all do not go for all these models without by your own. You take the suggestion of a specialist physician or an endocrinologist, and then you can try for it.
One question from Dr. Nishit Patel. After how much time post COVID DM recover?
So again, that is a big question. We do not have a concrete data. We are just all waiting for much more data on that, because some of the patients, yes, temporary hyperglycemia is seen, because I have seen discussions. I have not personally I have not treated a COVID-19 patient so far, but these are all from the discussions in various our endo groups and also some of the papers and all. Transient hyperglycemias are documented. Sometimes it has even reversed it within a month also, and some patients it has persisted also. All I think I would say that we'll wait and watch for the more concrete data on that part.
And one more question: is high protein powder recommended given in gym and all?
Not at all. Not at all. So you'll have to be very, very wary about it because gym and all. Last week only, I had one 21-year-old guy. Yes, this has become an abuse sort of model, and he was confessing me that he has taken all sort of steroids, danazol, testosterone, HCG. He has taken even a little bit of growth hormone, IGF-1 and all. So please be wary about all those things because many other things, all these protein powders do have mixes and all. So even if you want to go for the, you'll have to search for it. And I don't know whether I mean, like unmixed or unadulterated sort of powders are available in India. In American setting, I've seen some of the brands, but I don't know whether it is available over here. So always better not to take or not to overdo because this can result in because IGF-1 mixed and all can result in all sort of metabolic complications and metabolic derangements. So please do be wary about it before going for all these what say fallacy powders and all.
Another question again: safety of metformin during pregnancy. If this is not safe, what other anti-diabetic drug would you recommend?
Yes, so it's always a matter of debate when it comes to metformin. Recently, many other guidelines like Indian Family Health and Family Welfare have shown have advocated that metformin can be used in I mean, GDM, not pregnancy, not in the first trimester, but in the GDM, they have advocated. But many of the trials, like the recently published MITI trial, and also the previous trials based on the metformin in diabetes also have shown, metformin many times it is like an add-on. So it is like right now, the safety aspect in GDM is we are not worried about the anomalies, but recently some of the trials or the follow-up studies, which are all very small numbers only, have shown that the metabolic derangements can happen because of the nutrient restriction that metformin causes during the intrauterine life can result in overweight children in the adolescent age group or even in the early childhood group. So that studies are there, and but it is not totally contraindicated. It can be used along with metformin in patients with GDM. But my personal preference, as you, if you ask me, I will be more inclined towards the insulin than with the metformin. But it's not due to the contraindications. It is safely used. Even I have also used it. But if you ask me, just my personal inclination, I will to be with the safer with the insulin. And but there is no I mean worry on the anomalies part on the child if you use it in GDM.
And one last question:
Yes, sir.
um, in emergency surgery, can we go for sliding scale?
No, see, emergency surgery also. I have already put up the perioperative setting how to go about it. Sliding scale right now has been almost taken off, and if the patient is an emergency, I want to undergo emergency surgery. Start. I mean, check the potassium level. Check his glucose levels. You can start for the IV infusion. The potassium is normal. Start IV infusion. Check the potassium for hourly. Check the blood glucose monitoring hourly, and accordingly adjust the insulin doses. But that's the best way. Sliding scale has been taken out. In those patients who are not critically ill, as I already put up, you can go in for a higher dosage from the IV, shifting from IV to sub. You can go in for a higher dosage of the basal insulin, like 80% of the total requirement which was required for that patient can be put up as the basal insulin, and the supplemental correction doses based on checking the blood glucose 4 to 6 hourly daily. You can give the supplemental correction scale. Beautifully put up slide was there on the that is from the JCM article only, and that you can give it and post it on your wards, and even your staff nurses can follow it on that. So sliding scale is totally now out because the reason I have already put it up.
I think we have come to the end of questions. That was an
Okay, sir.
excellent presentation, Dr. Prem.
Thank you so much.
Loved it. I think most of us would have understood a better way of managing diabetes,
Right, sir.
at least for the patients on DFU and diabetes in general.
Right.
Thanks a lot, Dr. Prem. Then.
Thank you.